Um, like the part of hypertension which we covered. Any volunteer to discuss the topic? Any exam candidate? Just a starting. Why if you are dealing with any case and you came to know that the patient is hypertensive, okay? So what will you be expecting in that patient as anesthetist? Who wants to answer? Please, any volunteer? Um, okay. Actually, when you are dealing any patient and you came to know that that patient is hypertensive, so the main because not every hypertensive patient will be in the same line or will have the same risk. Um so how will you quantify that this patient is can create more problem? So that will be in the form of how much is the duration of the disease, how much is the microvascular and macrovascular complications, how is the compliance to the drug treatment, how effective is the treatment which the patient is taking, and then the problems related to the medications. Okay, so then if you just peep into the microvascular and macrovascular complications, so microvascular complications are in the form of retinopathy and nephropathy, and macrovascular complications is in the form of actually accelerated atherosclerosis. So it will become ischemic heart disease in the form of coronary vascular disease and cerebrovascular disease resulting in stroke or TIA, and peripheral vascular disease in the form of intermittent claudications or limb ischemia. Okay, so this is the just domain of the complications. We have actually discussed in our first session these things in detail. If you people have not attended, you can find it in the YouTube channel. Okay, so this is one thing. So today I will be trying to cover some of the aspects of the antihypertensive medications. And to know that, actually, as I started, as I just started, you should be knowing what is the pathophysiology. Okay, so any volunteer to tell what is the pathophysiology of hypertension? Any volunteer? Mahjabeen, Dr. Huria, anyone wants to speak out? Yes, please. What is the pathophysiology of hypertension? Can you people hear me? Am I audible to you? Yes, Mahjabeen. Is there any problem in the audio? Because I'm not getting any response from any one of you. Am I audible to you people? I don't know what's happening. Are you able to listen to me, or is there any problem? Can anyone respond so that I know that you people are listening to me or not? Is there any problem in connectivity? Can you people hear me?
Yes, sir.
sir.
Now,
Okay, so if we just want to target the pathophysiology of hypertension, okay. Just a second. Actually, I think there is some problem in the connectivity. I am unable to. Just a second, please. I think there is some problem in my internet. Apology for the inconvenience. Don't know what happened. So anyways, so we will just if you can, Zishan, if you can just highlight what is the basic pathophysiology in hypertension, what actually occurs in hypertension.
The physiology of hypertension. So, sir, most of the hypertension is essential hypertension, which is an idiopathic hypertension. No cause is known. But what happens in hypertension, there is mostly the peripheral vascular resistance is increased. There is systemic vasoconstriction. In the young people, we can say. Then there are the renin-angiotensin aldosterone system also plays a role due to the reabsorption of sodium and other thing, activating the angiotensin system.
Okay, so blood volume is increased. Okay, so there basically there will be problem related to the systemic vascular resistance, and there will be a problem related to increased blood volume. Okay, and then when sympathetic system is activated, the contractility is also increased, heart rate also increased. Okay, so why this is important to know, because when you are targeting the treatment, you should be knowing what is the pathophysiology. Okay, so then it will be easier for you to understand. Okay, so if you are, for example, if you are talking about so one of the thing will be preload. Okay, one of the most important thing which you should be targeting is the preload. Okay, so what medications should be targeting the preload? Like, for example, if you think about diuretics, how they are affecting the preload?
By decreasing the blood volume, circulating volume.
How they do it?
By excreting more fluid out of the system.
Okay, so if we just, for instance, would just try to recall what are different types of diuretics?
So, loop diuretics, Russian sparing diuretics, osmotic diuretics.
Okay, so you see, I will be just showing to you, just a second, please. Yes. So we are focusing on the first portion, which is affecting the control of blood pressure, that is in the form of preload. Okay, that's what we are discussing at the moment. So we will be just having a look on the diuretics. So if we start with just there are two ways to understand diuretics. One is in the form of different mechanism, or one in the form of the site of nephron. Okay, because basic principle will be that they will be acting on either of the place in nephron. Okay, and they will be affecting the reabsorption of certain ions. So just pardon me. Yes. Just a second, please. Okay. So osmotic diuretic, what is the mechanism of action of osmotic diuretics?
Sir, they create an osmotic gradient in the, I think the distal convoluted tubule or the distal collecting ducts. And through the osmotic gradient, because the osmotic gradient across the membrane.
The distal tubules or what?
Distal tubule, yeah.
Not distal.
Osmotic diuretics inhibit the reabsorption throughout the tubules, not only in distal.
Actually, they come in the lumen, okay, and they are dragging the water inside.
Volume outside, yes.
Okay, so their mechanism is just like they are the pressure builder.
Yes.
Okay, so this is the basic principle. So their use is in in any part of the body. If you there is like increased volume, they will be increased volume in the cells. They will if you give them, like when when we use mannitol in neuro, what is their role, how they affect?
Mannitol is hypertonic solution, so it drags all the water from the cells towards the vessels.
Yes. So what is the harm? What can be the problem if you are using mannitol?
It can dehydrate the cells.
No, that can be effect, but what is the more important? We are saying that they are bringing the friends outside from the
Yes.
cells in the intravascular space actually. Okay, so what can occur, because everything is being controlled, monitored by the heart. So if the volume in
Hypervolemia.
the vascular system is increased, so before this is excreted through the kidneys, they can create overload. So they can actually result in pulmonary edema. Okay. Understand? Because
Yes.
they are bringing the volume inside the vessels from the cells, and transiently they can cause increased overload. Well, like they can result in more volume inside the vasculature. So if the heart is unable to handle it, patient can go in pulmonary edema. Okay, so that is the thing which you should be knowing, that when you are using it, okay, because they are inert molecules, they are entering in the filtrate, and this action is in the kidneys. But before that, when we are giving IV, it is creating a overloaded environment in the vasculature. Okay, so this is the basic mechanism, and you should be knowing a little more about it when you are dealing in the neuro anesthesia. We can discuss about it, but the basic principle is like that. Okay, so what about loop diuretic? What is the main site of action?
The loop of Henle. Thick part
Thick
of
ascending
loop of
limb
Henle.
of
Loop of Henle.
loop of Henle. Okay, so thick ascending limb is usually permeable to water or impermeable to water? They are acting on the sodium potassium 2
It's
chloride.
impermeable, I think.
Impermeable. What are they doing?
The loop diuretics acts on that channel to put sodium potassium 2 chloride channel.
Yes.
They block
So,
that channel.
so that when ions will be there, so it will be creating the loss of both ions as well as water. Okay. So they are the most powerful diuretics. And they are available in the IV form as well. Furosemide. Okay. Do you know anything related to furosemide related to allergy? Anyone knows about it?
No, sir.
Just think.
Thiazide.
What is the relationship between loop diuretic and hypersensitivity or allergic reaction? Yes. Anyone?
Potassium supplement.
Anyone listening to my question?
What is the question
Yes.
again?
Is there any relationship between furosemide and allergic reaction? Is there any association? Dr. Soumya Sharma, would you like to answer if you know about it?
I'm not sure about it, but I think it's something related to sulfonamide
Not sulfur.
hypersensitivity.
It's related. You are absolutely right. It is related to sulfur drug. Okay. So the people
Yes.
who are allergic to sulfur drugs, they are not supposed to receive loop diuretics. Okay. So you
Right.
should be knowing. You should be knowing about the common sulfur drugs. Can anyone tell what are sulfur drugs?
Sulfonamides, there's trimethoprim.
Thiopentone. Sodium.
Thiopentone is also sulfur drug. Okay. So like their side effects is obvious. So if because they are causing the excretion of sodium, potassium, calcium. Okay. So they will be causing hyponatremia, hypokalemia, hypocalcemia. What else? Hypovolemia. Okay. So another side effect which they can ask you is related to autotoxicity. Okay. So especially if they are used with combination with aminoglycoside, they can cause significant autotoxicity. Okay. And another thing is that it is causing metabolic alkalosis. Why they cause metabolic alkalosis?
Cause of loss of sodium.
Actually, they not loss of sodium.
Sodium and chloride.
Loss of hydrogen. Okay. Because remember one thing.
Anion gap.
Yes, sir.
Remember one thing. Potassium and hydrogen are friends.
Yes.
Okay.
There you go, sir.
They go whenever there is hypokalemia, there is alkalosis. Whenever there is hyperkalemia, there is acidosis. So this is one thing which you will not forget. Okay. So the uses are usually acute pulmonary edema. They can be used also in low doses for renal protection. Okay, in the form of to keep the urine output maintained. Okay, another role is that like in any hypervolemic state, you can use them. Okay. So these are because these questions they ask in the MCQs. They can ask you, especially in the basic science exam, the people who are preparing for EDA exam. So if you learn in this a little bit interactive way or in the form of what is their site of action, then you will be able to understand the side effects and their you will not miss them. Okay. So next is thiazide diuretic. Okay. So thiazide diuretic acts on the distal convoluted tubule. Okay. And what is the peculiar thing about thiazide diuretic? Like what is the uncommon side effect of thiazide?
Potassium sparing.
Dr. Humera, try to answer correctly, okay? Because your answers are wrong. It is not potassium sparing.
Hyperuricemia.
Hyperuricemia is caused
Hyperuricemia.
by loop diuretics as well.
Sir.
That is the most peculiar side effect of thiazide is hypercalcemia. Okay. This is the only diuretic which cause hypercalcemia, or others cause hypocalcemia. Okay. And they are also causing all these, both of them, this one, thiazide and loop diuretic, cause hypercalcemia, hyperglycemia, hypercholesterolemia. Okay. Okay. So next come potassium sparing. So what do you mean by potassium sparing? Yes.
That it doesn't cause hypokalemia.
Hypokalemia. So what do you think their mechanism? Because which endogenous hormone cause hypokalemia in our body?
Aldosterone. Sir.
Aldosterone.
Aldosterone. Okay. So one of them should be aldosterone antagonist. Okay. So spironolactone is aldosterone antagonist. So they are affecting the opposing the effect of aldosterone. Okay. So there are few other diuretics like carbonic anhydrase inhibitors, and before it was old concept of using dopamine for promoting diuresis and for renal protection, but now it is not used. What is the role? You know, one thing about I missed about aldosterone antagonists, they are being used in especially in liver failure. Okay. Because there is high aldosterone levels. Okay. And so they are required in that condition, and they are effective there. Okay. And so, okay, so carbonic anhydrase inhibitors, what is their mechanism of action? They are acting on the carbonic anhydrase enzyme. Okay. And but what is the things which you should be knowing about carbonic anhydrase inhibitors? They are hardly ever being used as diuretics. Okay. They are usually used in other conditions like
Mountain sickness.
what is the
Glaucoma.
glaucoma. Okay, actually they are because they will cause metabolic acidosis. Okay, so acute mountain sickness, there is like they will be compensating the acute respiratory changes which occurs in mountain sickness. Okay. So I just try to cover the diuretics quickly, because there are so many important things, and there are so many MCQs which come from this topic. Okay, so we started from the concept that first thing to target when you are just a second, please. Where did it go? Yes. So one of the group is which effect on preload is diuretics. Okay. What other group? Renin-Angiotensin inhibitors. Okay. So what is the mechanism of action of renin-angiotensin inhibitors? AC inhibitors.
they stop the conversion of uh, angiotensin 1 into angiotensin 2 by
Okay.
inhibiting the angiotensin converting enzyme.
Yes. And so this is the like angiotensinogen is produced by liver. Renin acts on angiotensinogen to convert it into angiotensin 1, and angiotensin 1 is converted in the lungs into angiotensin 2. Okay. And then there are peripheral receptors of angiotensin. So they act over there. Okay. So the same enzyme AC is responsible for metabolism of bradykinin. Okay. So this is the mechanism of creation of dry cough, which occurs by AC inhibitors. Okay. So this is the reason because bradykinin causes cough. Okay. So so what will be the net effect of AC inhibitors? That they will be blocking this, because angiotensin 2 itself is vasoconstrictor, and it also increases the secretion of aldosterone. Okay. So this is the third thing which you should be knowing is the blockade of noradrenaline or reuptake. This is, I think, minor effect. Main effect is this vasoconstriction and aldosterone. Okay. So net result is yes, please. So net result will be
Net
that there will
result is
be
that the vessels won't be vasoconstricted.
yes, there will be vasodilatation. There will be decrease in volume. Okay. Decrease in volume because of decrease in aldosterone. So the net result will be decrease preload. Okay. By the way, what is preload? Can someone explain what is preload?
Preload. Preload is the volume in the veins, basically in that come before the heart.
But like you
Venous
can say,
return to heart.
venous return to the heart, and actually it is the one which will be deciding the, because according to Frank Starling law, contractility will
Afterload.
also no, the contractility depends on preload.
The
Okay.
stretch on the heart.
So it is just like you are when you are pulling a rubber band. Okay. So the more you will stretch, the far it will go. So that is the concept. So why preload is important? It is not only because of the volume is decreased. Actually, volume will affect the contractility as well. So indirectly, it will be affecting the this one contractility as well. Okay. Just a second, please. Okay. So what are important thing about AC inhibitors? What else you should be knowing? Because one is AC inhibitor and other is ARBs, angiotensin receptor blockers. So what is difference between these two of them?
Main difference is the site of action.
Okay.
The ACE inhibitors are blocking the angiotensin converting enzyme. Basically, they're enzyme inhibitors, and the other ones, the ARBs, they angiotensin 2 is formed, but it cannot act on the angiotensin receptor.
So mainly what will be the difference?
Difference is just their mechanism.
So
Because
there
the
will be
effect will
side
be same.
problem with the side effects as well, because when
Yes.
Yes.
this conversion will be stopped, then it will be affecting the bradykinin as well. Okay.
There will be no dry cough in ARB.
Yes. So there are
While
less side effects of ARBs. Okay. So what is the example of ARB and AC inhibitors?
Sinopril, captopril,
Yeah, these are
ARBs are losartan, valsartan.
Valsartan.
saralasan and losartan.
Yes.
Okay. So, what are the recommendations of American Heart Association regarding ACE inhibitors? Like, because
ACE inhibitors.
practically speaking about ACE inhibitors, they will be asking you, would you like to continue? Would you like to stop?
Kidney
They
function.
should be stopped.
On the day of
Sorry?
session.
Day of surgery, they should be skipped because they can cause severe hypotension while induction
Actually,
agents.
if you read the American Heart Association, it is not recommended to stop. Okay. When you are stopping it, sorry, when you are continuing it, you should be expecting more hypotension. Okay. But especially it will be depending that whether the patient is taking only ACE inhibitors or combination of medications. Okay. If patient is taking a combination of ACE inhibitors with calcium channel blockers or any other antihypertensive, then it is recommended better to stop. Okay. If you are giving it, you will be expecting significant loss. There is no like, it didn't say it depends on the hospital policy. Okay. Whether you want to continue it or whether you want to stop it, it will be individualized according to the patient. Okay. Like you use the word recommended, it's not like that. Okay. It is better to stop, but it is not recommended. Okay. Recommended means that definitely you have to stop it. What is difference, Zishan? If someone asks you what do you mean by advised, or what is the difference between recommended?
Recommended is that something that should be done, and advice is
It's in a better way. In a better way, it is that there are more benefits than risk. Okay.
yes.
So it is, or there is more risk than benefits, like on the either side. So whatever recommendation they do is on the basis of risk versus benefit. Okay. So about ACE inhibitors, they can ask you, because ACE inhibitors in other medical conditions, they are also giving it in diabetes as renal protective agent. They are giving it in heart failure as well to reduce the preload and afterload, both of them. Okay. This is something new for me as well. Arindropril for stroke. Such things you can, it is better even if you are reading the articles, because sometimes it is better not to reproduce everything you read, because you may be stuck in something. Okay. Because it is new for me. I did not recall this thing. But of course, you see, this is they are telling about some trial, progress trial, prindopril protection against recurrent stroke. Anyways, actually, when the blood pressure will be controlled, so automatically the risk of stroke will be reduced. Okay. So we can say here, just a second. You see, the same thing which I was telling, apology, just a second. The same thing which I was, okay. Suggests that continuation is reasonable during the perioperative period without stating whether it applies to specific risks pre-existing types of cardiovascular disease, class of recommendation, grade 2A. However, they also recommend that if ACE inhibitors are withheld before surgery, it is reasonable to start as soon as clinically feasible. Okay. So there, the consensus, there is no consensus guideline about it. If you are giving it, you can continue it or you can stop it. If you are stopping it, then you have to restart it, because if you stop it suddenly, there may be rebound hypertension. Okay. Anyways, or anything which is having some vasodilator effect, if you stop abruptly, there can be some side effects as well. Okay. So if you are continuing it, you should be expecting the more decrease in blood pressure. Okay, so this is about ACE inhibitors. Okay, okay. So what about calcium channel blockers? Yes, please.
Don't remember their mechanisms.
Sorry. What about calcium channel blockers?
They block the calcium channels, L-type calcium channels, and
Okay.
verapamil acts on heart, and those with dipines act on blood vessels, and the diltiazem is in between. It acts both on heart and blood vessels.
Okay. So another important thing regarding calcium channel blockers is that if you are using, for example, for instance, verapamil, what should be the protection for it? Like what you should not be doing if you are using verapamil? Yes, please. Is there any specific care we should be doing if you are using? If you are using verapamil, you should not use beta blockers. Okay, because if you are using verapamil and beta blockers together, they can result in heart block. Okay, but if you are using the peripheral like hydropyridines, dihydropyridines are the peripheral calcium channel blockers. Okay, so you can use them together, but not verapamil with beta blockers. So this is something you should be knowing about it. Then in MCQ, they can ask that this L-type channels are in the myocardial tissue. Okay, and there is other, what is the name? I think it is P-type, if I'm not wrong.
No ideas.
You can just confirm it. Anyways, so another thing is that these calcium channel blockers are being used for arrhythmias, like for example, verapamil or even diltiazem is being used. Then calcium channel blocker is being used in the to protect the cerebral vasospasm. Okay, so they are being used in subarachnoid hemorrhage. Okay,
Yes.
nifedipine and some, I think, peripheral vascular disease to reduce to make the decrease in SVR. Okay, then whenever you are using calcium channel blocker, you should be expecting reflex tachycardia. Okay, so this will be less with diltiazem because it has effect on both heart and as well as peripheral vasculature. Okay, so they have the same thing which I was telling you. Rate limiting agents prolong AV conduction and cause bradycardia. The negative. So, this is why it should not be used with beta blockers. Also, because both of them are what is inotropy, chronotropy, dromotropy? Has can anyone?
Inotropy is the contractility of the heart. Chronotropy is the rate of the heart, increasing the rate of the heart. Dromotropy, I've forgotten.
Conductivity. I always, there is another Bathismo something. So one of them is this conductivity. I cannot recall, but you should be just knowing about it. They can ask you. Okay. Okay. So now we have covered ACE inhibitors. Okay. Okay. Some words about beta blockers. Okay. So what is the things you should be knowing about beta blockers?
Beta blockers. Basically, they are not directly antihypertensive drugs. They are used primarily for cardiac protection, to reduce heart rate, to improve the myocardial oxygen supply demand. Sorry, myocardial oxygen demand.
And they have effect on
They have,
reducing the
yes, they have
blood
effect
pressure
on
as well, because when
blood pressure.
contractility will be reduced, okay, there will be reduction in the blood pressure as well.
Yes.
Okay, so but you are right that they have, actually they are to reduce the stress on the heart.
Sir.
Okay, so like they act on this beta adrenergic receptor. So you should be knowing that where is the location of beta 1 receptors and where is the location of beta 2 receptors. So beta 1 is mainly in the heart, and beta 2 is in the smooth muscles of vessels, large vessels going to the muscles, skeletal muscle, and in the bronchomotor tone. Okay, so that's why beta 2 agonist we are using for the management of asthma. Okay, but they are not specifically selective, so they have effect on the beta 1 as well. So whenever you are giving salbutamol or salmetrol, there will be tachycardia, there will be palpitation. Okay, but they can increase the blood pressure, but they can reduce it as well, because they are affecting on the blood vessels of the muscles. Okay, so or they can make, you can say that they will have less effect on blood pressure as compared to specifically. Yes, okay, so they will have less effect, but their effect may be unpredictable in that regard, because if, for example, there is tachycardia because of hypoxia, that tachycardia will be reduced actually. Okay, but because of their effect on the beta receptors, they itself can increase the heart rate and sympathetic activation. Okay, so it's a tricky answer for that thing. So that's why if the patient is in severe bronchospasm, sometimes practically, this is, I'm just telling you a practical thing, that if you are using low dose adrenaline for resistant bronchospasm, actually it can reduce the heart rate at that time. Actually you are using adrenaline, but because the reason for tachycardia is hypoxia at that time. So if you relieve the bronchospasm, actually the heart rate may reduce. Okay, so another thing, important thing which you should be knowing about beta blockers is their perioperative role, perioperative use. So what is the recommendation about it?
It should be continued, and if the patient was not taking beta blockers previously, he should start at least 1 week before the surgery.
You should not start it right before the operation.
Right before. Yes.
Okay, so they say that it increased the cardiac morbidity. This POISE trial evaluated this thing. So if the patient is on beta blocker, you have to continue it. And like another thing is that you like because it is reducing the stress on the heart, so actually they are even effective in the chronic management of the heart failure. Okay, though they are negative inotropic and negative chronotropic, but they can reduce the myocardial oxygen demand. So actually it can improve the contractility in that way. Okay, so this is how beta blockers, this is the significance of using, and this is the question they can ask you about. So what about beta blocker use in diabetic patients? They can blunt the response of hypoglycemia. Okay, because usually when there is hypoglycemia, there is sympathetic response. So if the patient is taking beta blockers, then this effect may be inhibited. So that is another thing which they can ask you about beta blockers. Okay. So
Can you show me the title of this article? Antihypertensive agents. Right.
okay. So some of the other antihypertensive like alpha blockers. Okay. So what is the selling point of alpha blockers? What you should be knowing about alpha blockers? Usually when their predominant effect is on alpha 1 or alpha 2. Yes.
There are selective and non-selective alpha blockers.
Mm-hmm.
The selective ones, I think they act on alpha 1. The non-selective
No, but
ones act
just
both.
when we are talking about alpha blockers, which receptors we are more interested in? Alpha 1 or
Alpha
alpha
1,
2?
sir.
Alpha 1. Okay. Because
Because they
alpha
are on
2,
vessels and they cause vasoconstriction. So
yes.
we are more concerned about if we are trying to control blood pressure, then we have to give alpha 1 antagonist. Alpha 2 is
Yes.
basically check of sympathetic system. If alpha 2 is stimulated, it will cause the overall inhibition of sympathetic system.
Yes. So that's why it is important to know. Another thing is that usually alpha 2 receptors are more presynaptic. Okay. So actually it's when their like stimulation occurs, actually there is decrease in sympathetic outflow, which is in the form of which medication is used for that purpose. What is the name of that medication? It is actually alpha 1 presynaptic alpha 2 agonist. What is that medication? Sorry?
Dexmeditomatine, clonidine.
And dexmedetomidine and clonidine. Okay. So that is a future medication. Like it's a wonderful medication. It's being used. Actually, it's just tell me one thing, an interesting thing. Is dexmedetomidine analgesic?
Also has
Yes, sir.
analgesic.
It is weak analgesic, and we are using it for sedation because it is a very good sedating agent, and it's
Okay.
like
So just tell me one
as
thing.
soon as we stop,
How
sir.
how it is causing analgesic effect? You will be surprised.
No
Dexmedetomidine
idea,
has
sir.
no analgesic effect. Okay. It is blunting
Yeah.
the response of sympathetic system. So actually,
Right, sir.
what is the response of sympathetic system? That is, whenever there is pain, there is
Tachycardia.
tachycardia, sympathetic stimulation. Okay. So actually, it is blocking that effect and it is causing sedation. This is the
Yeah.
effect. It does not have any analgesic effect directly. All other medications, because when we are talking about analgesic effect, analgesic medication, there should be some effect on the pain pathway. So it is not acting on pain pathway. Okay, it is modifying the response to pain. Okay, because why? Just tell me one thing. Why we use lidocaine, for instance? Do you know that lidocaine, now we use lidocaine as IV analgesic? Because if you are using lidocaine for a local infiltration, they are blocking the which receptors they are blocking?
Voltage gated sodium channels.
Sodium channels. So when you are using it as IV analgesic, actually it is also acting as a membrane stabilizing agent. Similar effect you get by giving magnesium. Okay. So they are membrane stabilizing agents. They are also blunting the sympathetic response to pain. Okay. So this is something extra I just wanted to tell. It just came into my mind to tell you. So alpha blockers, when we are using, usually they these are, you can say, the slap on the sympathetic system. So usually they are causing sudden hypotension, and it can cause reflex tachycardia. Okay, but main alpha blockers are used in BPH to reduce the prostate size. Okay, and this is one of the most common. I cannot recall, if someone can correct me, I forget about it. Labetalol has both alpha 1 and alpha 2 effect. Which is more? Alpha 1 is alpha blocker is more effect or beta blocker? I think it has more alpha effect. Am I right? If you cannot recall it, just
Effect is more.
confirm it. Okay, I think it has more sensitivity to alpha receptors than beta receptors. Okay, so just reconfirm it. I cannot recall at the moment, but you should be knowing it because they can ask you in an MCQ, or as a concept you should be knowing. I think, if I'm not wrong, if it's 20 times more alpha effect than beta effect. Okay, but what is, what is the advantage if you are using, for example, the pure alpha blocker versus combined alpha beta blocker? What is the advantage of using labetalol?
It avoids reflex tachycardia.
Yes, because it is, whenever we are using, I just mentioned a few minutes ago that whenever you are using alpha blocker, there is reflex tachycardia. Okay, because when there is vasodilatation, there is sudden decrease in blood pressure. So as a reflex, tachycardia occurs. Okay. So similar opposite effect is with phenylephrine. So if you are using phenylephrine, what occurs?
Bradycardia.
Reflex bradycardia. Severe vasoconstriction, reflex bradycardia. So you should be knowing. If you have the concept, you will not forget. Okay. So there are certain other directly acting vasodilators like hydralazine. Okay. So hydralazine is acting directly on the smooth muscles, and it has similar sudden like hypotensive effect with reflex tachycardia. Okay. So yes, now nobody is using it, but as in the classification, they are also mentioning ganglion blockers. I have never used it. I have no idea how to use them, and they also cause hypertension. Okay, so I just tried to cover some of the aspect. Actually, I was very rusty today, sleepy, and sleepy. So I apologize that things were not very good today, but I hope you understand some of the points. Yeah, methyl dopa. I just came. What is the special thing about methyl dopa?
So it is also an alpha blocker, and it is used in pregnancy.
Yes, it is the one of the medication which is safe to be used during the pregnancy in the Aldomet, which is being frequently used. Okay, and okay, any questions, please? Okay, so inshallah we will discuss some of the topic inshallah tomorrow. Okay, bye bye.